Camille, I think we'll hand it over to you. People have signed on and more will sign on. So Camille, it's all yours.
Well, thank you so much, Vivek, and it's a pleasure to be here. I'm Camille Nebeker. I'm an associate professor in the School of Public Health at UC San Diego, and I've had the pleasure of directing a center that we've received funding for from the University of California, San Diego, that's called the Research Center for Optimal Digital Ethics in Health. And so my work has focused in two areas. One is how do we do digital health, mobile health research ethically and responsibly? The other area is a lot of work in developing community capacity and working with underserved populations. And now those two areas are really intersecting in my work, trying to figure out how do we bring a lot of the digital tools that we're using into communities that are traditionally underrepresented in our research. How do we introduce mobile health and do this in a way that's going to be culturally appropriate and respectful? And a lot of my background has been, I spent 20 years working with institutional review boards, and I directed and created the program at San Diego State University, the Human Research Protection Program. And then I transitioned over to UCSD in 2013, and I was on the IRB there for, I think about 4 or 5 years. And I got really frustrated because it wasn't very progressive. And they weren't basing any of the decisions that they made about risk on actual evidence. And so in 2013, when I joined UCSD, I was asked by my colleagues in behavioral medicine if I could help them figure out how to navigate the IRB, because they were using new digital technologies to capture behavior in real time in natural environments. And so they were using, this was pre-Fitbit. So there were no commercial products on the market. They were using research grade tools to capture behavior in real time. So wrist-worn sensors, patches that they would tape to the person's thigh, wearable cameras that would capture what you see in that person's environment. So first person perspectives using a wearable camera. And so you can imagine what an IRB might be thinking. Like what are these data that they're capturing? What rights do the people have that are on this camera that never volunteered to participate? And so the new issues, the new kinds of data, the imagination of risk was really capturing the IRB, and they were making decisions that were incredibly conservative. Either they were completely missing the risk or they were overstepping their role and thinking that none of this can happen. So they would just shut down potential studies before they could even get started. So we started, we got funding from the Robert Wood Johnson Foundation to create a platform that's called the Connected and Open Research Ethics Platform. And our goal in doing that was to bring the research community together to share what they were learning, how they were developing their protocols, how they were communicating technologies in their consent forms that IRBs were approving. So it was basically a database of what was working for IRBs and researchers sharing with each other how they were getting approval so that they didn't end up waiting 8 to 9 months to get something approved. So I'm going to put in the chat here, the core platform that I just mentioned is under reconstruction right now. So the platform is offline, but you can sign up for, if you go to the core platform on that link, you can sign up to be part of the community. And this is a community where people are asking and answering questions about digital health and how to do it responsibly and ethically. So I think this is, you know, I would encourage you all to think about engaging a research ethicist that is really keen on knowing how to think through these risks and how to communicate them to IRBs. But I also encourage you to start thinking about how can you incorporate aims into your study design that help you understand what are the actual risks. How do people experience these technologies? How do you know whether or not your communication during the consent process is actually working to inform people? These are all really new questions that I think would be important for you to be gathering data on as part of your research study. That way you can inform IRB decision making. At this point, everything is relatively subjective. So oftentimes my colleagues that are doing designing these studies are actually communicating quickly and often with their IRB analysts to help them understand what these data look like, where they're being stored, how you're communicating information to the potential participant. So you're in a role right now where you're learning how to do this, but you're also in a role where you need to communicate to your IRBs what this is and develop a relationship very early with them so that you become partners. And IRB analysts and members want to help you get to where you want to go. But right now, the way that relationship looks is that we throw things over a wall and we hope for the best. And you really need to take the steps to create that relationship with the IRB, because they are a gatekeeper for you. And they don't know what you're doing. And it's new, it's innovative, it's novel. And for IRBs, it can be very scary and they're risk averse. So start with that relationship early and start paving a pathway of educating the IRB as you're educating yourself, and then incorporate aims into your study that you can deploy to learn what is effective consent, what are the actual risks, what works to mitigate those risks. And I think I should just stop there and see if you all have any questions. And Vivek, is there anything that you wanted me to hit on? Because I want to make sure Scott has time to talk about his piece. I can't hear you.
After 8:30, it takes a little time for our scholars to warm up. So you might as well give them words of wisdom, like strategies, places where they can go, template IRBs. I find it's, the IRBs have this very convoluted forms. I find there are some of the language on the Recode site useful that has been vetted. Maybe you can point them there.
Yeah, like I said, the database where we have all of our protocols and consent language is offline right now. It's temporary. We're just rebuilding it so it's more user friendly. But this is where, I mean, this community that you have and the community that we've created on the Recode Health platform, it's a place where you can ask and answer questions of your colleagues and other people that have had a lot more experience than you have. Our advisory board includes Donna Metz, Eric Heckler. I'm involved with the Society for Behavioral Medicine. I'm on the Digital Health Council. We have a lot of people with a lot of experience. The thing about IRBs is that they all make decisions independently, and it's hard to find out what the standard practice is going to be. And so even if we have an IRB approved consent that you could use to borrow language from and try to cobble together your consent to submit to an IRB, oftentimes the IRB that you submit to will find something wrong with it. And so we can't come up with a perfect prescription, but we as a community can help each other think through how to communicate what the risks are, because we're gathering all of that experience right now. And so in one of the cases where we were using the wearable camera that it was on a lanyard and it was, hanging about chest high and it was pointing out here, we asked participants, we actually did a study after the IRB said, no, you can't do this. And, oh, this is going to be too risky for people. The bystanders that are captured, they need to consent to, all of these different ideas of what was risky. We actually asked participants, what you've experienced wearing all of these things for a week? What did you experience from other people that you were around? Did anyone comment about the camera? Did you forget to use the privacy button? Is there anything we didn't tell you up front that you wish we had told you? So we were really checking on whether or not our consent process was actually useful. The IRB required that we give every participant a card that they could use. They could look at their card to explain to another person why they were wearing a camera. Nobody used the card. They said, I forgot I had a card. And I said, so what did you say to people when they said, what is that thing you're wearing around your neck? And they'd say, oh, it's a camera. I'm in a UCSD study. It's about my behavior in everyday life. And people would say, that is so cool. How did you get into this study? You know, there was one person out of 328 people that we interviewed that said, oh, I don't want to have my recording. I was with my cousin for 20 minutes. My cousin didn't want to be on the recording. Can you take that segment off? You know, so we allowed people to go through all of their images, to take out anything that they did not want to have in that recording. So we gave them complete control over all of their data. They lasted about 10 minutes when they were starting to go through all of the data that was collected on the device. And I think they found their life to be relatively boring, because, you know, after 10 minutes of looking at yourself going through the grocery store or going to the park or getting in your car, you know, you kind of think there's really nothing here. Now, the thing about the wearable camera is that it can capture things that are reportable. And so you also have to give people fair warning that if you do something that's illegal, we definitely want to take that off, or you need to take it off. But if you don't, it could be reportable. So there are some things that we have to think about when we think about risk. And it's hard for me to talk about risk because it varies depending on who your population is, what kind of technology you're using, where the data being stored, who has access to the data. If you're using a commercial technology, what I'm really concerned about is what that third party is doing and what terms of use you've committed to, and whether or not the participant understands that a third party has access to very granular data about them. And so you could say, I can avoid that because I'm going to only enroll people that are already using a Fitbit and have already agreed to the terms of service. Well, that's a really select population. So you're going to already compromise your study by only enrolling people that have already purchased something. So, you know, when you use a commercial entity as a component of your study, one of the things that you can find on the Recode Health website, I worked with John Torres. He's a Harvard psychiatrist, bioinformaticist, digital health expert, and Rebecca Ellis, who is at Indiana University and also is really well-versed in using digital tools, technologies for health research. We worked together to develop what we call the digital health checklist. Now that is on the website that I posted on the chat. I'm going to put it here again, just in case people have joined. So the digital health checklist was created through an iterative human-centered design process where we engaged with different stakeholders that were using digital tools. We were trying to figure out what questions you need to ask yourself when you're making a selection of a digital technology for use in your research. So the first portion of it is, and it's all anchored to ethical principles. And so when you think about the ethical principles of respect, beneficence, and justice, those are all anchored to data management, risk and benefit assessment, privacy, and access and usability. So when you choose some technology, you're going to want to make sure it's accessible to the people that you want to use it with, that it's been tested on those people, that they can use it short-term and long-term. And I know that those are more a feature of, will it work for my people? But these are all ethical questions, because when you design a study, you want to make sure you're designing it for the people that you want to enroll. So the first thing, you want to make sure they can use it, that they can use it short and long term, that it's been tested with them older adults is a population I work with a lot, as well as underserved populations. And so these technologies, they have not been tested with these populations. So I get a call from the Google Tiger team about 8 months ago saying, how did you ever think to test these technologies with older adults? What made you think that? And I said, because they're the fastest growing population globally. And, you know, if we don't know what technologies work for them, we're going to miss them. We're not going to be able to connect. And the pandemic was a real eye-opener about how older adults use technology and or have access to it. And so you have to test these things with the population that you want to use it with. Risk and benefit varies by group. Access and usability, privacy preferences are different with older people than with younger people. You know, so the digital health checklist is available to all of you. You can, you know, we have a passcode that you need to be able to access it because we want to know who is accessing our material. So you need to ask for the checklist, that we send it to you as a PDF. And I think that is a tool that would be really useful. You can see the references on the website. You can see the framework when you land on that page. The PDF is after you request access, we'll send that to you.
There are a bunch of questions popping up.
So I'll stop.
No, there are a bunch of questions. So I think they're in the chat.
Yeah, I'm wondering
with Lauren
about mHealth interventions involving adolescents, social media, privacy and confidentiality. Are social media interventions ever confidential if Instagram and other sites see that data? That's a great question. And I think that's really important because social media is being used increasingly for really sensitive interventions with youth, with men who have sex with men, with people that have stigmatizing mental health conditions. That's one. Social media is very popular for those types of studies. And how do you convey whether or not that information is private? This is all part of consent because you can't guarantee confidentiality in most cases. You can't guarantee de-identification in most cases. So I think having those kind of conversations with your prospective participants is really critical. Let's see, do you have any advice about risk, privacy, and collecting passive smartphone data with young adults who may be in higher risk situations like foster youth? Any considerations to think about? See, this is something that I call data literacy. And I don't think people are really aware of how much of their information is being pushed out on their text messaging, on their tweets, on whatever they're, however they're communicating. So it's really critically important for you as the person or your team, whoever is conveying consent information, that you are able to convey this information in a way that's accessible. So on the digital health checklist, the first row is about respect for persons. Respect for persons is demonstrated through the consent process. And so when you look at the matrix that we've created, you will see that how to convey privacy. We give you some checklist items about what you need to think about when conveying information about privacy, risks and benefits, access, and data management. So you can't make a lot of statements that you can't make claims that you can keep things private. And so then you have to talk about what are the potential risks if information that you convey gets out. You know, there's also some things happening with Facebook where they're running their predictive analytics to identify suicidality. And so we're trying to be very transparent about how the algorithms are developed, how they're making decisions, how they're being trained. All of those kind of things, I think we need to be more clear and transparent about when we are engaging in informed consent. A member of our team mentioned that if the participants utilize their own smartphone, then the certificate of confidentiality does not apply and the government can still ask for the data. I don't know if that's the case.
Okay. To provide some context, we are, along with Michelle, who asked the previous question, our group is focused on studying foster youth who are transitioning in that adulthood period. and using multiple sensing sort of technologies to indicate psychosocial stress. And we talked about doing GPS location. We were a little worried about whether or not that population would feel comfortable with that, but we said we could sort of ensure confidentiality. And the member of that group sort of mentioned that she had heard, or another collaborator she was working with, that certificate of confidentiality cannot be maintained if it's their own smartphone. So we were all quite surprised and wondering perhaps where we could maybe learn more about that.
That's a great question. I had not heard that. But I think, even when you tell somebody, somebody from the NIH would have to speak to the certificate of confidentiality, because I have always wondered how solid it was, because I've not seen a lot of cases where it's been tested. But in terms of somebody's own smartphone, I think there will probably be limitations to it, because the FCC or whatever federal organization oversees that, it seems like there are limits. But GPS in and of itself, when you convey to somebody that you have access to their location data, they don't understand what that means. I mean, you can even show them what their data look like, and it's so abstract that it's really, really hard to let people know that you can actually know where their movements are. So I think from a consent perspective, it's really challenging, because people don't understand that concept of having their longitude and latitude mapped for every minute, And so you can see where they are, and they don't understand that can actually happen.
That's interesting. Actually, I didn't think about that, and not having done that before. I'm sort of curious to know if that's the case when you've come across sort of consenting, then if there's language that you've used to help with that, or...
I think that's the kind of stuff that I'm saying we need to test what's working.
Okay.
So my colleague that was trying to convey to adolescent girls in a study she was doing in Eastern or Western Africa, she said, I'll be able to know where you move all day long. And so when they met back in person and she was looking over the data, she asked the subject in the study, why is it you're visiting the market every night? And she said, I don't go to the market. And she said, but it looks like you're at the market every single night. And the girl was selling water at the market, and she thought she would get in trouble if somebody knew that she was selling water at the market. So even if you show them what that actual tracing looks like, they don't conceptualize it because it's not their data. But when you show them their data, like even if you were to have somebody wear a GPS for 20 minutes and go for a walk, and then they come back and you show them, this is where you went, they can actually conceptualize that was me that you just tracked. If you show them somebody else's data, it doesn't seem to resonate that could happen to them. So anyway, I'm just saying that these are the kind of questions that we need to be asking and collecting data on in conjunction with your study. You need to be asking the foster youth a lot of questions about their expectations, so that you can then understand, what do they find risky? What would be acceptable to them? What would be a deal breaker? Because I don't know, I'm not a foster youth. I think you really need to engage them in that process.
Well, that makes a lot of sense. And our group was discussing that as, as a whole part of the AIM, and even based off of one of our speakers yesterday. So that's helpful. Thank you.
Welcome.
I think Diane has a question about the parental permission in adolescents.
Yeah, so to provide a little bit of context, this is not related to our project, but I'm a psychologist and I work with trans youth. And, one of the limitations is that, there aren't a lot of trans competent mental health providers, especially sort of in sort of rural or outside of urban settings. And so some of the work that I've been doing is to develop, digital mental health, CBT based interventions that sort of account for minority stress, and to deliver these interventions digitally through an app. And some of the things that we've been struggling with is, like that one of the barriers to access is that some of these youth are not out to their parents as transgender. And so requiring parental consent to participate in a digital mental health intervention, I would guess some youth would not be willing to do that, to sort of out themselves to get parental permission. And I've had some folks sort of say, like, it's a mental health intervention for at baseline high risk for suicidality sort of group. How will you get around that from an IRB standpoint? So just curious if you had thoughts or experiences around this.
Yeah, I think about my years in IRB land, and there are ways, the beauty of the regulations is that they're so flexible that if you understand them, you can always use them in your favor. So understanding the regulations is a really powerful tool for all of you. So, and also talking with the IRB person as you're planning your study is very important, because you can ask for a waiver of parental permission. You don't always have to get it. And if there is a likely benefit that outweighs the potential risk, and that parental permission is a barrier to access to participating in a study for a youth that could in fact benefit in some way from participation, they have the power of waiving that requirement. So you have to know to ask for it. And knowing that there is, whether it's in your situation or whether it's in a situation where you want to modify consent so that you don't tell everything that you're trying to learn up front, or you want to modify some aspects of it, you have the ability to do all of that in the regulations. So it tells you, I think it's in 46.117. So 45 CFR 46 is the federal regulation for human research protections. You can read the common rule, which is the first part of it, which is what all of the federal agencies have agreed to. That's why it's called the common rule. And it talks about, consent, and it talks about when you need to document it. And it talks about when you have the right to augment it, change it, when you have the right to request not to document, because in many of these cases, the documentation could in fact pose more of a risk to a person just by signing a consent form that says, we're recruiting you because you meet these criteria, right? So you can always ask for a waiver of documentation and a waiver of the information that goes into the consent.
Thank you.
You're welcome.
I have a couple questions. One is so in collaborations with commercial entities or nonprofit organizations, as opposed to university-based research project teams, are there substantial differences in terms of the ethical standards of practice when you're looking at the digital tracking data? So, for example, the commercial applications, if you're collaborating with a company versus, a nonprofit organization, hired a third party to develop an app and then say wanted to work with you as a researcher to look at the overall aggregate data. And versus, we have a, interdisciplinary team across different universities and recruit participants. Of course, then you have to get a consent. So are there substantial differences or recommendations in terms of these kind of practices and the standards and principles we should follow?
Yeah, there's a lot there, Helen. So look at the digital health checklist. That's going to give you a really good starting point for when you are going to a third-party app. You need to know what's under the hood. You need to know where everything is built and how it works and where the data will go. Academic organizations, any research organization that accepts federal funding to conduct research is bound by the federal regulations for human research protections. A nonprofit or a commercial entity that conducts research but does not receive that federal funding has no commitment to follow those federal regulations for human research protections. So if you partner with Facebook or you partner with a small health tech startup, you are bound by regulations, they are not. Okay, so you, in that partnership, in that collaboration, have to follow your your regulatory requirements, but how do you do that in a way that allows for that partnership to happen when they don't have the same acculturation to ethical research practices? And they may have different ideas about how to proceed. They may have different ideas about what works for their community that's really worth listening to and learning about how our practices may not fit with their practices. So you need to have a lot of conversations early and often about what you're bound to do, how you can take what your requirements are and make it work for that setting. But to do it in a way that is respectful and that is appropriate culturally. So it does take time, and there are really distinct differences.